Welcome to the Talking HealthTech podcast. My name is Peter Birch. Today in this episode, we're going to dive deep into interoperability, what it means, why it matters, and how we can use technology to close care gaps and improve patient outcomes. In this episode, I'm joined by Dr. Monica Trujillo, Chief Health and Risk Officer at Telstra Health, Rob Reynolds, Vice President of Clinical Reasoning at Smile Digital Health, and Dr. Janice Tan, Clinical Director at Telstra Health and Deputy Chair of the Central Eastern Sydney PHN Clinical Council. Hey team, how are we going?
We're good.
Hey.
Good to be here.
Hello. It's great to have you all here. And this being an episode as part of a little mini-series that we've been running on the Talking HealthTech podcast, it's great to bring together the Telstra Health team and the Smile Digital Health team to really explore, I guess, the different ways that health information exchanges can help clinicians access more data, use it more effectively. And today I feel like we're going to unpack some of that and help provide better understanding and perhaps some clarity too for anyone within this space looking to have an impact, because I'm actually keen to hear from each of you just in terms of the work that you're doing within your organizations and in this digital health landscape, particularly with these, I guess, emerging tools or evolving tools that, I think we've all got this consistent goal of trying to improve patient outcomes, which usually requires clinicians having access to the right information at the right time. But Monica, tell me a little bit about the, no stranger to Talking HealthTech, of course, but to set the scene, tell us a bit about the work you're doing in the space.
Well, I think I'll start with, and we've talked about this before as well, many clinicians are still working with a lot of fragmented data at the moment, and what is real and what is not. There's fragmented data, but also large amounts and very quickly turning the evidence-based practice. So you have this large amount of information coming at you, but also have fragmented data from across the area that you're working in a fast pace, and you also have limited budgets, whether it's clinician, community, enterprise. If you think about it and look back, you blink and you think, we haven't quite progressed that much. But then you look back and you see things like, the difference FHIR has made, the WHO having now the computable guidelines. I mean, when did we think we were going to have that to address gaps in care? So I think that's where we've focused in. Where can we make a difference here and now, rather than that concept of, those rip and replace and put in big systems to try and address everything, is how do we build from the current data sets that we have, make it more accessible, make it flow better, and make it sure that the clinicians can trust it. Because that's the other thing, right? If you have information in front of you that you can't trust because it's poor quality or it's variable, it's like not having any information because it's work, right? So that's what we're targeting. And so our partnership with Smile, the work that we're doing is really addressing to, and we've talked about, big works. I forgot what we called it last time. I think we said we're on a highway. It's not a three-lane highway. It's like a 7-lane highway. It's really creating. Yeah, I remember that. So it's really creating those foundational pieces that we can get that information that is relevant to that, not loading people with a lot of information. We need to put at the time relevant information with the right clinician and the consumer and the carer, right?
Yeah.
So that's what we've been working on.
Yeah, no, that's so true. It can be easy to we're so focused in the doing of healthcare, and you forget how much progress there has been, and use that as inspiration to continue to build. And yeah, you're right. There's so much healthcare to do right now that using what we've got and the assets and using those more effectively. I'm keen to dive into that a little bit more with you in a moment. But Dr. Janice Tan, Telstra Health,
yes,
tell us about what you're up to.
So I'm the Clinical Director of Primary Care and Enterprise at Telstra Health. So I work with Telstra Health's primary care softwares, but also their smart connected care suite of products that enables like emerging technology like AI scribes, FHIR-enabled e-referrals into to be sort of placed into our existing software. And that really goes in line with Monica's thinking, where it's trying to make sure that we expose our existing clinicians who are used to our software into new products and new emerging technologies. above all that, I'm also still a practicing GP in Sydney. So I work 2.5 days as a GP in Sydney. I still see patients and I still experience a lot of the pain points that many doctors in Australia still experience when it comes to data accessibility.
I love that. The closer we can get the two different hats that we wear to look the same, right? There's the innovative, forward-thinking digital health hat where we're like, oh, wouldn't it be great to do all these things? Then you put the reality hat on of like, this is what healthcare looks like on a day-to-day. The closer we can bring those two things together, I think the better outcomes for everyone. Rob, tell us a bit about the work you're doing.
Yeah, so at Smile, we're constantly doing a lot of things. It seems like every day we have more functionality coming out. So I'm very focused on clinical reasoning. I do everything clinical reasoning. And what we mean by that is we take the knowledge that has been gathered about healthcare by all of those professionals who work in that space, and we apply it to the clinical data to generate, value for the clinician and for the patient. So I'm off in my own little world, geeking out on, stuff like clinical quality language and CQL and quality measures and clinical decision support and gaps in care and that type of thing.
Almost uncovering the how we can use this information better to serve a patient better or inform clinicians to help them make better decisions too. So I'm keen to dive into that a little bit more with you all. But back to Monica for a moment. You gave a bit of a high level overview in terms of what's keeping you busy within this landscape. But then I think about Australia specifically because where we're all interested in health information exchanges. There's a lot of interest and excitement and opportunity for us to really kind of take this interest and excitement within the industry, but then actually take some action. But I'd love to hear from you about like the role that you think that things like HIEs, health information exchanges, and clinical decision-making tools can actually have a meaningful impact to address some of these problems that we always talk about, bridging care gaps and supporting outcomes across primary care and hospitals and aged care.
A lot of people don't know how wide Telstra Health is in terms of their software. And so if we just go to the software, we go all the way from, as Janice said, primary care, community-based care, aged care, we look after hospital care, we have population care, health solutions, we have pharmacy as well. And so, and the reason why and we've got an analytics AI ecosystem, and the reason why I'm saying is because we've got our own, we're sort of a reflection internally of what the system is out there, right? So we've got our own software that we've come either by acquisition or we've built our own or whichever way it is, and we're faced with the same problem internally, right? Because we've got our aged care solution being deployed in aged care, and then we've got the solutions in GPs, and we've got solutions in hospitals. And for us internally, and it's a problem, as I said, we sort of reflect, we're a mini ecosystem of the wider issues as well. And for us when we looked at how many of those have when we looked at trying to integrate it, it's not that easy. So we know how hard it is. Different languages, anyway, we all know how hard it is. And when we looked at it, there's a lot of commonality, right? There was a lot of common. You need patient identifiers, you need allergies. You said, there's a lot of common things that we tend to do differently anyway. And they're built different, and they're not. Anyway, long story short, which you all know about, which is the reflection of where we currently are. That's what we embraced. We know standards is fundamental. We embraced FHIR as a standard. We embraced Smile as a partner. If you think about, just hearing Rob's title, he's the VP of Clinical Reasoning. It's like, oh my gosh, imagine saying that to our clinician. Let me introduce you to the VP of Clinical Reasoning. I don't know how it'd be really interesting in this role to have a role with clinical reason, but this part, it's so important, right? Because when you build it, we know how difficult it is to get those systems now to start talking to each other. So it is fundamental, the work of standards. Super supportive of the work Spark is doing. We're partners 100% with Spark. We're partners FHIR in actually putting those foundations and bringing in a FHIR first sort of health ecosystem. And that's really important, but as well, going back to, the transitions of care where most people fall through, that's also the value where HIE is. So we know that, the work that the Commission did years ago, it was those transitions of care that created the big risk areas as well. So that's where HIE can definitely tackle, but also the wider vision of building something that will have a good way to connect all that, which is FHIR-based. So for us, both things are really important because not only do we serve our customers, but internally, that's a problem we struggle as well. So we've got the similar problem that we want to solve, and we think this is really a way forward.
Yeah, it's sometimes forget to reflect on that rather unique position that Telstra Health has of as you say, being like a micro ecosystem, given the breadth of the systems, and given that it's in the early days growth by acquisition, that you've got the same challenges that anyone else operating in the system does. So there's definitely a vested interest there, and love that we've got those insights from you in relation to that. Rob, just reflecting on the points Monica made in relation to, those care gaps and the role of clinical reasoning. I'd love to hear from you in the work that you do and how that resonates.
Yeah, respective to the HIEs and the fragmented data, an HIE for us is really the holy land, the holy grail, because garbage in, garbage out. If we have a segment of data, we don't have all the data, and we're doing clinical reasoning, we're getting bad results. We're getting less than optimal results. So getting all the data is absolutely paramount to our work. And, we all know that getting all the data is one thing, but we need to get all the data in a common representation. Otherwise, we're spinning our wheels, spending all of our time trying to figure out how this thing relates to that thing and how this data relates to that data. And that's not where we want to be. Where we want to be is in a standardized representation, ideally semantically standardized representation, but we'll take on a little bit of that work, if not fully semantically interoperable. And then we can really start focusing on those value propositions that clinical reasoning brings with those higher level use cases. But specifically to the care gaps problem, I'm just a bit concerned that we're just accepting this care gap thing as normal. In my opinion, they're a symptom of the silo that we've historically had between quality measures and clinical decision support. When these things kicked off, when we first started digitizing these things, we didn't have sufficient standards in place. And when we started implementing these systems, we did so in a way that caused them to evolve into these silos that were completely separated, often organizationally, not just technologically. But that was accidental, not necessary, and it's actually quite the opposite. In the States, CMS and ONC, who I think are roughly equivalent to obviously Medicare Australia, but also the PBS, ADHA, and PRNs. I guess the combination of those two are kind of like that set.
And the commission, probably. I would add the commission.
Yeah. Thank you. Yeah. Yes, thank you. But those entities realized this over a decade ago, and they set out to do something about it, and they created the CQF framework or CQ framework initiative for exactly that reason, to address this. And they were convinced that harmonizing these two technologies was really the next stage of transformation of healthcare quality. And why would they think that? It's because it all falls back to the clinical practice guideline. The RACGP peak bodies or peak body and the other peak bodies, they know when a gap is going to happen, and they know what to do to prevent it. So, I think the question we need to ask ourselves is, why are we gapping in the first place? Again, CMS and ONC saw this a decade ago. And NCQA, they were there too. And there's a little bit of buzz around CQL right now, at least in the States, with CMS moving their measures to FHIR and CQL, and NCQA moving their HEDIS measures to FHIR and CQL. And I think as humans, we tend to think, we saw this thing or learned about this thing today, so it must have happened today. I think things occur when we hear about them. But CQL was created over a decade ago, and it was created for this purpose. It was literally part of the CQF. I keep saying CQF framework. It was literally part of the CQ framework initiative to fix this problem, harmonize clinical decision support and quality measures, which, I mean, if you kind of step back and think about it, this was a big enough problem that entities like CMS and ONC got together, not only to adopt new standards like FHIR, which is kind of a big deal, but also literally to create new standards in order to fix this. And so I just think it would be a tragedy if we didn't, continue that movement forward.
Leapfrog, right? Like, we have the opportunity to leapfrog. So, and thank you for our US communities for suffering for the 10 years. But, we have the opportunity to leapfrog some of that and get the fast track some of those learnings and make sure that, we're not going through another 10-year journey as well. Because for us in Australia, and, Janice will know this, well, we have the Atlas for Variation in Healthcare. So your outcomes sometimes rely on your postcode. Nothing else, right? It's your postcode. That gap between rural, metro in outcomes for the same condition is significantly different. So, I mean, we actually have a challenge as well to make sure that we leapfrog and learn and address and make our vulnerable communities that, rural, regional, access those and have that quicker than not wait 10 years. But anyway.
Yeah.
And I think there are those technology challenges that you can leapfrog. But I also think it's a little more systemic than that. I think the lack of the standards resulted in the silos, but somehow that's become ingrained in our view and our thinking about healthcare. I hear things like, and maybe this is only in the States, but I hear things like, let's look back, 12 months, or let's do a year-to-date care gap, and we're going to call that prospective care gaps. And I just can't help but think, what's going on? How is looking in the past prospective? To me, perspective would look something like we're looking in the future and we're identifying the risk of a gap. And then we're figuring out what to do to prevent that risk from ever even happening, which is possible, by the way, for a subset of measures. And not only possible, but relatively simple when you have this harmonization between quality measures and CDS. It's very, very difficult to answer that question. What should we do to prevent this from the way the quality measure logic is structured? And it's very simple to do from, the way the clinical decision support logic is structured. So we have these, through that 10 years of pain, we now have these harmonizing standards in FHIR and CQL. And yeah, certainly there's another leapfrog there that I think we can take.
I'm keen to dive into the what do we do about that, and a little bit later in this conversation, or because I think that's a clear picture in terms of where we're at and highlighting the problems. And it feels like sometimes, in healthcare, I'm not sure if it's, why are we, I think you said before, why are we still gapping? And there's probably, I'm curious in your thoughts, maybe we unpack it in a bit, but whether it's, because it's a super complicated problem, whether it's a problem that doesn't have an immediate impact, so it's not a great big fire that needs to be put out now, or maybe it's a combination of everything. But I guess if I was to use an analogy, that Australia and the US were on a bushwalk or a hike, depending where you are in the world, and we've already sent the US through the the first bit, and they got all the cobwebs in the face, and they got the sticks that whack them when they come through. And so we've got the potential to follow some of that path or maybe take a new one. But I guess we actually need to know where we want to go in the first place to then see if it's the same one or whether it's different, because different healthcare systems got a lot to learn from each other. But Janice, in the primary care space in particular, I'd love to hear from you. As you said, you see it in the real world, and you know the problems that need to be addressed head on. Where do you see that that say primary care providers can, or practitioners can, leverage some of these connected care solutions to address the problem we're talking about, close the patient gaps and reduce health inequities?
Yeah, no, absolutely. And Rob, I just like to say, I love how Smile has a clinical reasoning business unit, because honestly, you cannot do proper clinical reasoning without comprehensive data. Because without sufficient clinical data, you're not doing any clinical reasoning. You are just making clinical assumptions. And assumptions can be dangerous because they are influenced by bias, indirectly or directly, and has shown time and time again to lead to poor health outcomes. So in the primary care space, I think it's really important for connected care solutions to provide enhanced data accessibility to comprehensive patient records. So where, for example, my practice, right, has 4 hospitals around it, north, south, east, west, within a 15-kilometer radius. And each of these hospitals have their own services. So like the hospital in the north has a really good aged care social work service, hospital in the south, more complex oncology services. And I have had patients who attend, say, 3 of these hospitals within this radius for specific services. But unfortunately, in 2025 still, I do not have a comprehensive view of all their journeys within all these different hospitals, mainly because, these hospitals operate in different local health districts. And, I don't have the current technology to be able to access all the information and the journeys of the patients in this hospital. So really having a centralized source of truth for all their patients' progress and journeys with these hospitals will be able to help me as a GP coordinate their care better. And we've seen that already in primary care. We have the My Health record, which, the government has stood up to try to ensure the sharing of real-time patient data. And I have had some benefits of accessing this sort of real-time patient data in terms of helping me commit and perform to the best of my ability as a GP. Again, another example, I had a patient with chronic end-stage kidney failure on the transplant list, frequent hospital readmissions due to the nature of their kidney failure. And one day they came back with an abnormality in their blood tests. And from the My Health record, I was able to access all their previous blood tests, whether as an inpatient or an outpatient. And also, not only that, access the plan from a subspecialty that was consulted in the hospital to manage this blood test abnormality. So then this empowered me as a GP in the primary care setting to manage that patient as an outpatient without sending her to the emergency department, so preventing any unnecessary hospital admission. So from that very simple example, you can see how important and crucial a centralized source of truth and, and the importance of a GP or any primary care providers having access to a comprehensive patient record.
And add to that, if you think about, Janice, you're in a metro area, right? Like you are in Sydney, you're in a metro area, you're trained GP. But if you think about our rural, and, for Australia, we don't have a rural workforce where it actually might not be a GP, it will be a healthcare practitioner of some sort. How much having, the right guideline for that, addressing that gap in care in a remote area brings up whole community practice, right? Like it's if you think about how we're large, the beautiful large sunburnt country, which some other countries have similar, Canada, there's remoteness, rural, even regional areas where you don't have visiting specialists or you don't have a particular area, like the guidelines and healthcare providers feel vulnerable as well, then having access to what is it about this patient as a whole, what guideline do they fall in, how can I address these gaps in care, that is standards of practice at the moment, just supports even the workforce feel that they can do a better job, right?
If I think too, like if it was just an issue of let's just make sure all of the information is available to anyone that's looking after a patient, if the practicalities of it, if a patient was to walk into a new setting or go to a different care provider, probably the first thing they're going to say, if they were inundated with a bunch of information, they'd be like, how about let's start from scratch, because I don't fully understand what's going on. So Rob, is that where like the clinical reasoning side of things come in, saying just because there's a heap of data doesn't mean that that's actually useful?
Absolutely. I feel like clinical reasoning's job is to help present the correct data or the interesting data, as well as generate additional data. So there's a set of data that's available that are the features of the patient or the clinical state of the patient. Some of those are in a very, let's call it primitive state where, yes, clinicians can use them, but it takes a lot of brain power. It takes a lot of brain power to look at these different things and say, oh yeah, if I do this calculation in my head and inference this from that and the other thing, I can put together this pathway that tells me where the patient's at. Well, let's jump in. Let's have a computer run those calculations, make those inferences, elevate that data, and present to the clinician those higher order, if you will, data that allows them to then use their clinical mind to make, these decisions. That's one part of it. And that's on the data side. The other part of it is we all know that knowledge is just exploding. It's not just in the clinical space or the medical space. It's exploding everywhere, but it certainly is exploding in the medical space. And so what we're saying is, we have a human being, a doctor who is ultimately a human being, and we're saying we have this knowledge that is growing at an insane pace. We want you to pack it all in your head, and then in a very short period of time, pull out only those relevant bits, and then in a very short time, apply them only to the state of the patient that's in front of you. And it's crazy. We wouldn't ask that of anyone. It's just way too much. We have tools for these things. We're using them in other areas. We really, really need to start making this a sensible thing and take all that knowledge and make it, use the tools we have to make it useful.
Absolutely.
Robert, you just say actually, and you'll be liable for it as well.
Oh,
right?
I'm sorry. I usually add that too. And then we're going to hold, I usually add that too. So thank you for calling that. Then we're going to hold you liable if anything goes wrong. I mean, come on. Was making sense?
Absolutely, Rob. I think thank you for acknowledging a huge pain point that a lot of clinicians go through, right? So there's a huge number of guidelines out there that GPs can refer to, and they often exist in different planes of the internet, whether it's through like the RACGP, like our college, peak bodies like the Cancer Council, but they can even be hidden in some like hospital protocol PDF as well. And a huge pain point for us is knowing how to find them when treating a patient in real time, but also knowing when they have been updated to reflect best practice, because there's not usually a big media announcement about that. And the thing is, medicine's becoming increasingly complex. Our patient population's getting older, more comorbidities that interact with one another. And it's also evolving rapidly with more evidence that comes to light. So there's just a lot of expectations upon clinicians and GPs in particular to manage increasingly complex conditions, especially given the access to specialists. So the need to access the latest evidence and best practice guidelines has never been so strong. And that's where I see a connected care solution, like emerging technologies as well, that can help with that, where they can provide information to our fingertips so that we can empower both the clinician and the patient to make the right health decision for them.
Yeah. I think a lot of the times, part of the challenge in addressing some of these complex problems is the understanding and clarity on what are we actually trying to solve here. And sometimes we can go into a bit of a cycle of the day-to-day without actually really clearly understanding not just the problem we're trying to solve, but why. But I feel like this conversation has provided a heap of clarity in relation to that. I guess my last question to each of you before we wrap up then is what you're doing about it specifically, what you're excited about, what's motivating you, and perhaps the call out to, given that healthcare is there's a lot of stakeholders involved. It's definitely a team sport. So, everyone needs to come along the journey. So I'd love to hear from you in your kind of closing thoughts too, like who are the stakeholders we need to rally to be able to kind of keep this momentum going? Perhaps Monica, if you were to open us up, and then we went Janice and Rob to finish.
Interesting comment, Pete, because when you think about healthcare as a team sport, is where's the patient? Is it that ball being passed around? Is it the goalie? Is it the coach? It's more of a personal thing. It's like, we have to bring in the patient in this journey, as well as we think about how we're building their goals in care. I think where we're going is that these guidelines need to have my goals in care, my dad's goals in care, as well as part of it, and make the consumer a true part of that journey, and not be that ball that gets passed around. It's an important thing, and that's just a sort of a more of a personal view rather than anything else, because it does. If I'm currently a carer for someone, it is an interesting journey to be in as well. But in terms of where we are and what we're doing, I think the fundamental work that we're doing, setting those foundations, embracing FHIR, making FHIR ready, making those standards, so at least the information that goes from one to another is the same. And then also the work that we're doing about, and what Janice was saying, about making it relevant in context to that particular consultation when it turns up. Because, you have 15 minutes to decide what to do with that particular patient. You don't have time. You have to give it through easy, accessible. And it might sound easy, but all of that, going back to the healthcare ecosystem, requires a fair bit of work and making sure that you have solid foundations and standards are there and the foundations are there. So you can run any sort of intelligence on the top or any stuff, but if you don't have good data foundations and a good set, you really, like Robert said, it's just like rubbish in, rubbish out, and clinicians will stop trusting it, really.
You've got me. I'm going to be reflecting on that for a bit, Monica. If healthcare was a game of soccer, which one is the patient? And I feel like right now that sometimes some patients feel like they're a spectator that's outside the stadium with a ticket that doesn't let them into the thing, but the game keeps going on. So you'll probably hear that from me. Actually, I'm going to steal that analogy from you for future episodes. So you can credit back to that one. Janice, what about your thoughts?
So I guess my big North Star here is to help to continue to foster and work on the alliance and co-design relationship between tech providers and developers, as well as clinicians as well. Because there's this whole notion that emerging tech will replace clinicians eventually, and that's not true. Emerging tech will continue to empower clinicians, and to be able to do so, we need to get that co-design right from the beginning as well.
Love it. Rob, what about you? Close out.
Yeah, I just want to double click on both of those. First of all, the patient and where they fit into this. Part of how I got so impassioned in this is, and I won't name any names, but I was talking to a CTO about using a patient-facing app to help them interact with their doctor probably about 8 years ago. And I got told, why would I give you my data? And that just kind of stuck in my head, and I went home, and at one point I was sitting on my couch and I was thinking, and I was like, I just couldn't get it out of my head. And I thought, it finally came to me. What was bothering me? That's my patient. That's my data. That's not your data. Why would you give my data to me? Because it's mine. And so, yeah, I definitely feel like if I see those data about my healthcare, I'm more likely to do something about it. Personally, I've started ordering my own, diagnosis tests when I can. I often think as I'm driving down the road, there's probably a quality measure being evaluated about me. Have any of you ever seen your quality measures? I haven't. I may have a gap in care that has been calculated about me. I've never seen a gap in care. So it really is the case that this game is going on and the patients are outside the stadium. They don't know, all these plays that are being made. And so what I do day to day is I'm kind of obsessed with two things. And one of those is getting that data correct so that, the work that I do is correct. And then I want to get there is so much knowledge out there. It's intractable right now. We can take little teeny bites, but that's not sufficient. So I'm kind of obsessed at the moment with how do we get a grip on all of this knowledge and start taking large chunks and get these large chunks of knowledge computable so that we can start using the power of the computer to make things better for everyone.
Yeah. Love it. Look, well, I would love to keep this conversation going, but we're going to pause it here and then pick it up in future episodes of the Talking Health Tech podcast as we continue this mini-series around connected care with Telstra Health and Smile Digital Health. So, Monica, Rob, Janice, I really appreciate you making the time for this conversation. Can't wait to do it again. Thank you so much.
Thank you.
Thank you.